maybe Ingrid and then Alicia here. Okay. So I will start. Okay, so today's topic, we're going to be talking about the promoting a culture of prehab for the surgical cancer patients. This is the topic we'll be discussing today. And one of the reasons why I chose this article was, well, mostly because to promote therapy growth in our cancer department program, but also because we're trying to grow OT in the cancer center as well. Right now, we're doing a lot of the post-op and just post-surgical, but also just cancer patients in general. But I wanted to kind of introduce this topic so that we can hopefully integrate a little bit more of like the prehab that I think physical therapy has been doing. And also hopefully this impacts the multidisciplinary treatments and referrals. And then the quality of life for our cancer patients. Pre-op care period has received a little attention, so I wanted to bring that up. A lot of it is focused on post-op care, and also just having to share this information with family and friends or others who may benefit from this. Okay, so defining cancer prehab, what is that? It's been defined as a process on the cancer continuum of care that occurs between the time of cancer diagnosis and the beginning of acute treatment, and includes physical and psychological assessments that establishes a baseline functional level, identify impairments, and provide interventions that promote physical and psychological health to reduce the incidence and/or severity of future impairments. Okay, so the aim of this study is basically the study is a narrative review of all the current literature on surgical prehab and discuss the current evidence of the pre-op interventions before cancer surgery in order to increase physiological reserve before surgery and accelerate post-op recovery. This study also aims to convey the concept of prehab within the context of the ERAS program, which stands for Enhanced Recovery After Surgery. It includes about 3 core modalities of prehab, meaning exercise, nutrition, and anxiety reduction. So my PICO question or patient problem is we have 112 patients undergoing colorectal surgery in a randomized controlled trial. And then the intervention was received, basically they received home-based program, which was either a sham intervention control group with basic recommendations to walk daily, to breathing exercises. And then the other one would be receiving home-based high-intensity training program consisting of both aerobic and resistive exercise. So the outcome, patients in the control group perform better than those who engage in intense exercise, of whom a large proportion deteriorated in functional walking capacity during the pre-surgical period. Compliance was recorded as a 16%, indicating that exercise regimen could not be maintained. Oh, sorry. Okay, I just started sharing now, so. Can everyone still hear me?
Yes, thank you.
Okay. Sorry, I don't think I was recording.
You were sharing your.
I hit record.
Okay.
You're good.
Sorry, so I haven't been recording it. I just realized that I think we should record it because I think you posted, Alicia. So I'm gonna just go off where we left off. So here. Okay, so the outcome. Predictors of poor surgical outcome included pre-surgical deterioration, ages of 75 years, and high levels of anxiety. These results support the notion that intervention based on intense exercise alone may not be sufficient to enhance functional capacity if other factors such as nutrition, anxiety, and optimized perioperative care were not taken into consideration. So then they had this other literature article review that talked about this study where it was a pilot study followed by randomized controls trial of 164 patients undergoing colorectal resection. And they used this multi-model prehab program versus the other one that we just talked about, composed of moderate intensity physical exercise, complemented by nutritional counseling, protein supplementation, and anxiety-reducing strategies compared to the control group that was conducted. The outcome of this, it showed that more than 80% of patients were able to return to pre-op functional capacity by 8 weeks, compared to 40% of a control group. So you can see on the diagram right there where we all start at that point A. When you had no prehab, you kind of stay at that zone, and then after surgery, you kind of dip down, and then your recovery starts there. But when you start with prehab, before the surgery happens, you started to kind of going on an uphill already before you go to surgery. And I think we all kind of can attest to that happening even with our ortho patients. And there's that dip and the increase in functional recovery post-op. So kind of talking about the exercise aspect before surgery, patients increase their physical activity levels within the relatively short period time frame to meet current guideline recommendations. Exercise training is based on the principle of overload. Thus, as the patient becomes accustomed to the intensity and adapts to the demands of the exercise performed, the intensity must be increased. Must be a balance between the ideal intensity amount of exercise as proposed by the existing guidelines, exercise principles, and what's feasible for the patient. So this is the kind of a nice table I found about physical exercise goals in pre-surgical period. So if you have a goal of reducing sitting or sedentary time, then these are the guidelines and how often you should be doing it and examples of that. And then if you want to increase your health benefits, you want to achieve 30 minutes of physical activity daily, 30 minutes every day, and then some examples of that in functional form. And then if you want to improve cardiovascular fitness benefits, that's what it should look like. And 150 minutes spread out over a week, brisk walking, swimming, and then dancing. That kind of reminds me of what Dee Dee has been doing over here as well with her dancing class. So I thought that was nice. And then improve skeletal muscle fitness benefits and also flexibility. So they have the guidelines and how often you should be doing this and some examples for the patients. And then now we're going to talk about the second aspect of the ERAS program, which is the nutritional part of it before surgery. So in this article, they talked about protein and how important it is, right? Protein requirements are elevated in stressful states right now, such as cancer, or to account for the demands of the hepatic acute phase protein synthesis and the synthesis of proteins involved in immune function and wound healing. Non-surgical nutrition oncology guidelines on nutrition suggest that cancer patients should consume at least 1.2 to 2 grams of protein per day. And this is a nice table also that was included in the article. And they talked about the standardized protein meal plan for prehab patients for breakfast, lunch, dinner, or post-exercise. And then the last part of it, the anxiety state of surgical cancer patient. We know that the presence of psychological distress, specifically anxiety and depression, is very common in these patients with cancer diagnosis. In the context of surgery, psychological distress has been shown to impact on wound healing, post-op pain relief, longer hospital stays, and more functional limitations. Evidence supporting the role for psychological prehab before surgery um, comes from controlled trials that they did for breast cancer, colon cancer, prostate cancer patients. In a study, they found they did with 100 patients enrolled to show the impact of prehab in patients with colorectal cancer resection. They found that at baseline, about 42% had high anxiety. At baseline, they had 32% felt like they had depression. And then for the outcome, the people that were able to complete this prehab program without dropping out, their depression score on the hospital anxiety depression scale at baseline was significantly higher than after the program, where they showed it was a decrease. And then they also talked about an article, Williams and colleagues found that women undergoing mastectomy or hysterectomy who received pre-op intervention meant to prepare them for surgery were better able to perform ambulation and rehab tasks, self-care activities 1 month after surgery when compared to women not receiving these interventions, the pre-op interventions. So how does this relate to our patients? Surgical cancer patients are seen by all disciplines across the continuum here in outpatient, inpatient, wherever, and it's possible that they have a comorbidity of cancer, despite whatever they're coming in to be seen for. People are now even living longer, people are aging and living longer with various comorbidities, including cancer. What evidence-based practice from the study can we share? So with the increasing number of patients with comorbidities as a result of lifestyle and aging, it's necessary to integrate prehab with the elements of the ERAS program that we talked about. Reports have investigated nutritional and psychological intervention in combination with exercise in a randomized control trial. Some of the strengths and limitations to this article, strength being that previous human studies on prehab have addressed the impact of physical activity and exercise on post-op outcome, like for example, surgery or hip, knees, and cardiac. So with that being a strength, we also this is also beneficial for also cancer patients related. And then most studies, it indicated that there's a positive effect of prehab on post-op functional capacity and return to daily activities. Some of the limitations that they had on this article was that the limited number of patients scheduled for elective cancer surgery and the exercise was the most used intervention. Some evidence, such as multidisciplinary programs, can address limited evidence, such as multidisciplinary programs can address modifiable risk factors that may impact the outcomes, and whether prehab can be applied in most of the surgical specialties. So some thoughts and questions that kind of arise from this study for future studies. What is the role of different types of exercise, the importance of nutrition optimization, and psychological stress reduction in order to increase physiological reserve in anticipation of what could be the treatment, either surgery or chemo or radiotherapy? And then what is the effectiveness of single and multiple modalities, their cost effectiveness and short and long-term impact on clinical outcomes, such as length of stay, hospital readmissions, ED visits, perioperative complication, and oncologic burden and adherence to adjunct treatment. And then some of the outcome practice changes. I hope to see that hopefully that we can get the word out and continue education, that referral practices for PT, continuation for PT, and potentially with OT for prehab, even dietitians for referrals for prehab, involvement in OT and prehab. So with us being able to work on the problem solving before they go through like surgery, guided imagery for like relaxation and coping strategies to help them prepare for their surgery and what to come, especially with this with the diagnosis, and education for the patient and family. And this also kind of brings in a holistic approach with prehab. And then these are my references. And then that's it. Does anybody have any questions?
That was really good, Karen. Thank you.
Yeah. Okay. Yeah, you're welcome. Yeah, so then I'll post this or I'll send this to you, Alicia. I just stopped recording, so there. Okay. If that's pretty much it. If anybody doesn't have any questions or anything like that.
I have a question. It's more program related. For I know you're sending everything to Alicia, and she's posting it and putting it. You're putting it on the SharePoint site too, right, Alicia?
No,
Okay, okay. So just posting it, right?
I'm just uploading the videos onto YouTube and sharing the files.
Okay. So I was just wondering for the articles that the people are working, like for example, because this is I think a great reference article, Karen. So I'm just wondering for the articles that people are presenting, are we doing anything with that, or are we just having like the video that we that you download or that you save, Alicia?
In the video, the citation to the article is in the description, and they can use that to go to PubMed and download onto their computer if they'd like.
Okay, okay, perfect.
Yeah.
Karen, can I get a copy of this article, please?
Yes.
Okay, thank you.
Is there another way that we should upload these articles somewhere that maybe we can access it? Maybe people that maybe aren't able to attend. I know you have the YouTube videos, but
Yeah, that's kind of where my mind is, but it kind of just
try to put all the article up to a SharePoint folder.
okay.
yeah.
Now, do we mean the articles or the PowerPoint? I feel like articles are incredibly easy to get to.
We can do the PowerPoints if that's what you're referring to.
I'm thinking maybe both the
Both?
article that you're presenting and potentially not necessarily the PowerPoint, but maybe the video. I think we should be able to add the link that you created, Alicia, to our SharePoint site. I don't see why not. So we could do a folder. I was just thinking going forward, right? Obviously the clinical ladder is new and the journal club presentation is new. So I was just thinking about ways that we'll have, kind of historical collection of what we've been working on. And also so people could look at, like Alicia was saying, and Karen was saying, we could reference it after the fact. So, but I'm just thinking for it to be in like a centralized location. So it would be nice, I think, to have